The Mona Lisa 7 trial was the first trial dedicated specifically to premenopausal patients in over 2 decades, and certainly the first one that uniquely looked at CDK4/6 inhibition only in this population of patients. So it's very meaningful because 20% or so of patients present in the premenopausal state, and we really don't have formal data that this clearly effective class of drugs in postmenopausal patients will work the same way in premenopausal patients. And while there may have been some premenopausal patients treated in very small numbers in the other trials, this one has enough power not only to ensure that the benefit is there and similar to what we've seen in postmenopausal patients, but to look at subgroups of patients, patients that have different sites of metastases and over different ages and different prior therapies. The other thing that's important about this study is it not only looked at aromatase inhibitors, which is a typical endocrine agent for patients with advanced breast cancer, but it also looked at tamoxifen. Again, all patients had ovarian suppression, but only at the time of their diagnosis. So this really gives us confidence that we can use these drugs and get the same benefit, and that tamoxifen can be used in cases where, for example, the side effect profile might be better with that compared to aromatase inhibitors. This was a population of patients that were initially presenting with metastatic breast cancer. So they had not had any prior endocrine therapy for advanced breast cancer, but they may have had prior treatment if they had early stage breast cancer previously. And about 60% of patients did start with early stage breast cancer, and they may have received chemotherapy and endocrine therapy, and then they recurred. However, at the time that they developed metastatic breast cancer, they could only have had one prior chemotherapy for advanced breast cancer and no prior endocrine therapy. I'm not actually sure that we will see a survival benefit. It's possible that we may, but the trials were designed statistically with the number of patients to detect an improvement in progression-free survival. And part of the reason is that we're not sure how well we could even possibly show that a drug might improve survival when many of these patients are going to get multiple therapies after they progress, and that clouds our ability to look at survival. Now, I think most of us agree that survival is an important endpoint. It just may be hard to detect it in this population of patients. Now, of course, we may detect it as more time goes on. At this point, the number of deaths is very small compared to the number of progression events, but over time there will be more events to be able to compare and make some statements about that. So this study also looked at quality of life because survival is very important, progression-free survival is important, but I think all of us agree that quality of life is important even in the absence of a survival benefit. So quality of life scores were obtained over the course of the study and did show that the deterioration that we might see over time in patients with advanced breast cancer was delayed or less was seen in the ribociclib arm, and that was statistically significant. So it was gratifying to see that. In terms of other side effects that we saw in this study, we saw the typical types of side effects that have been seen in other studies with CDK4/6 inhibitors. We saw some degree of fatigue. We saw lowering of the neutrophil count. About 10% of patients had grade 4 neutropenia, but that was typically asymptomatic. Only 2.5% of patients actually had febrile neutropenia. And in terms of other side effects, non-hematologic side effects, these were very similar to what one typically would see with aromatase inhibitors and tamoxifen. There was some prolongation of the QTc interval. About 7% of patients had prolongation, but in no cases was it symptomatic or did it lead to arrhythmias or anything of that nature.